hence, not surprisingly, the aftermath of COVID-19 has made a very significant impact on the ophthalmology in India as well. Since the lockdown has happened, patients have been willing to postpone their appointments instead of taking the unnecessary risk of contracting the virus at the clinic or the hospital. This pandemic and its consequent restrictions also bring immense financial, logistic, and psychological challenges for the patients. They face difficulty in maintaining all the rules of social distancing in a public setting, may also fear the risk of being prosecuted in case they reveal their travel history at the hospital during the questionnaire. All these factors make their simple visit to the hospital very tedious unless absolutely mandated. We have seen that there are reduced footfalls for the OPD walk-in patients. Only emergency cases are being seen in the OPD and also for the surgery. Tele-ophthalmology has been picking up and bridging the gap, although in very small parts. For poor patients in remote rural areas with no phone, this follow-up is also not possible. In remote areas, rural medicine supply for cataract surgery patients has also been drying up. Hence, as COVID-19 pandemic rages in the country, visual impairment could turn out to be one of the biggest challenges facing healthcare providers as eye-related procedures take a backseat. This is leading to the progression of severity of the conditions and blindness, which are actually preventable with timely diagnosis and treatment. In fact, experts predict a sharp influx in the number of blind people in India owing to delayed or discontinued treatment. Considering the necessity of addressing the concerns related to vision care in India, this online regional conclave assumes a great significance. I'm happy that we have such eminent experts amongst us from this domain today for sharing their thoughts and perspectives. Today, as part of the conclave, we'll get an opportunity to hear the perspectives through special talks from senior representatives of prestigious organizations and doctors working in the domain of eye health. This will be followed up by panel discussions of the experts on patient-physician collaboration to manage eye disorders in COVID-19 and public-private partnership to achieve Vision 2020 goal. So without taking much time, I would like to invite Srimati Ambili Vijay Raghavan, who is Chief Operating Officer, Aster MedCity, Kochi, Kerala, for delivering the welcome address to the August gathering. Over to you, Ms. Ambili.
Thank you very much, Swati. Good afternoon and namaskar to everyone. Dr. S.V. Chandrakumar, Project Director, State Program Officer, Tamil Nadu State Blindness Control Society. Dr. Neena Rani, Deputy Director, National Blindness Control Program and Visual Impairment, Government of Kerala. Expert speakers, eminent dignitaries from states, doctors, healthcare officials, patients, and patient advocates. I'm honored and privileged to welcome you to this South India Conclave, Spotlight on Visually Impaired in the wake of COVID-19, being organized by FICCI today. I'm also thankful to Novartis India, Vision 2020, International Agency for the Prevention of Blindness, Vitrio Retina Society of India, for supporting this initiative by FICCI. As Swati mentioned, in the face of the COVID pandemic, visual impairment could run to be the biggest challenge facing healthcare providers. This is primarily because eye-related procedures have taken a backseat. FICCI is currently organizing region-wise state online conclaves on vision impairment in East, South, West, and North of India. The first of the series, East India Conclave, was held on the 22nd September, covering the states of Assam, West Bengal, and Odisha. So the regional conclaves are being organized with the objective to discuss some of the current challenges faced, government approach, new advancements in eye care technology, increase in patient awareness during the COVID pandemic. And therefore, this becomes a really important initiative. I extend my best wishes to FICCI for organizing this very timely conclave and extremely crucial for that matter, covering the entire spectrum of eye care. and getting the focus back on patients during these times. I'm sure a lot of important aspects will be discussed today by a panel of eminent speakers. My best wishes for the success of the program, and it's heartening to see that initiatives such as this are happening, and I look forward to more such dialogues to achieve the goal of universal prevention of blindness. Thank you very much.
Thank you, Ms. Ambly, for the address and the apt context setting. With this, I am happy to share that we have Dr. S.V. Chandrakumar, who is the Project Director, State Program Officer, Tamil Nadu State Blindness Control Society. I would now welcome you, sir, for the keynote address, please. Over to you.
Good afternoon to all of you. I wish to thank the organizers and our Principal Secretary Health, Dr. Radhakrishnan sir, who in the last minute gave me an opportunity to participate in this meet. So at the outset, I would just like to briefly summarize care services in our state. The majority of the eye care services is done by NGOs, private hospitals, along with government hospitals. Here in Tamil Nadu, we have 22 medical college hospitals, around 38 district hospitals and 16 sub-district hospitals which are taking up the eye care services, around 360 ophthalmologists and 308 PMOAs. Recently, we have started 32 telemedicare centers, and they are also doing teleopthal consultations on participation with Aravind Eye Hospital. So in this, we have regularly every year, we take around 2.5 lakh cataract surgeries on participation with NPCB, and totally overall around 6.5 to 7 lakh cataract surgeries in our state. And around 11,000 eyeballs are collected every year. We give 2 lakh free schools spectacles for school children. And this year we have also decided to start giving free spectacle for old people to correct presbyopia. And we are ready to roll out. And for the current year, we are newly proposed 3 mobile ophthalmic units which are going to be launched. And we are also regularly supplying equipment to strengthening of district hospital, sub-district medical college, and under a Japanese collaboration JICA program, in which high-end equipments are given to medical colleges. So this year we have also started building a center of excellence for RIO at a cost of 64 crores, and a regional eye care center at Tanjavur for 16.5 crores. Apart from this, every year we do new OT and post-operative ward construction in district hospitals, 5 per year. We have already completed. And we have a special ROP screening program, and we have provided green laser with laser IDO and red cam to all zones and all district hospitals of Tamil Nadu. So with this, we are trying to move forward into a very good performance in eye care and to satisfy the objectives of Vision 2020. And I also would like to mention that as soon as the COVID pandemic came and the lockdown was announced, we put down our knife on stopping all the services were permitted from government as well as NGO side. We have also stopped all the home-based cornea retrieval program, and we were just doing HCRP on non-COVID patients. So as far as NGOs under NPCB as well as government hospitals, till September, late September, no cataract surgeries were performed, except a few secondary glaucomas and hypermature cataracts. But slowly the private hospitals and NGOs started doing their private surgeries, and now our mission director has given permissions to follow the guidelines of safe ophthalmology practices issued by Government of India and resume eye care services in the state. So with this, there is an added disadvantage in government hospitals because most of the eye wards and eye theaters have been converted into post-COVID special theaters because they are mostly isolated in the hospital. So with this, we have now, till September, October, from April, we have done around 16,500 cataracts, and we have retrieved around 200 eyeballs. And we are yet to start the school-based services because the schools have not come. This is a small overview of what has happened, what is regularly happening in our state under NPCB, as well as how we are slowly trying to come over the post-COVID pandemic crisis. but we are not able to fully operationalize all the activities. But if we do not get more cases, positive cases in future, government will just give us guidelines so that we will start receiving the eye care services in a full go and complete the maximum extent possible our targets in the forthcoming 3 or 4 months. Thank you.
Thank you, Dr. Chandrakumar, for sharing those details and perspectives. With this, I would also request now Dr. Neena Rani. She is Deputy Director, National Blindness Control Program and Visual Impairment, Government of Kerala, to share her thoughts and perspective. Over to you, ma'am. Dr. Neena, you are on mute right now. You would have to unmute yourself. Dr. Neena?
Here, madam?
Yeah, we can hear you, but we cannot see you. If you can also switch on the video, please.
Video share. Okay. Can you see me?
Not now, not till now. Yes, we can see you. Yes.
Yes, ma'am.
See, okay. All the respected and the participants of this meeting, I am Dr. Neena from Trivandrum, and I am the Deputy Director Blindness Control Program of the Kerala State. Have one regional institute of ophthalmology at Trivandrum. All the 14 districts have district hospitals, and all the other taluk hospitals and taluk headquarters hospital where ophthalmologists are providing services. And before COVID, everything was okay, and they had provided the social service to the society through the OP and as the surgery, the field activities like the school school screening, then old age screening, old age home screening, etc. Madam. But due to COVID, most of the services are nowadays for the last 1 year. We can say like that. But in the Regional Institute of Ophthalmology and also in the taluk hospitals, if any help-seeking persons, that means if any person need any services, they are providing it using the PPE kit, and they are also doing the emergency surgeries also, but no other elective surgery or elective procedures they can't do. That's the situation in Kerala at present, madam.
Yes.
Right. Thank you, Dr. Neena, for sharing your perspective. May I now invite Dr. Kim for his address on technology for last mile eye care in India. Dr. Kim is Senior Consultant of Vitreoretinal Services and Chief Medical Officer, Arvind Eye Care Hospital. He has keen interest in surgical retina and also has a special interest in telemedicine. He is one of the early pioneers to introduce teleophthalmology in India. Mr. Sundar Pichai of Google has honored him by nominating his work as one of the best to happen in the next 25 years in the Wired magazine. Over to you, Dr. Kim.
Thank you, Mrs. Swati, and thank you all for this opportunity to speak at this forum. With COVID, I think suddenly everything stopped globally. People were not accessing care, and then in many places, the caregivers also were not available. It was like a shock for everybody. Nobody knew what was happening. The doctors also immediately after the shock started panicking as we were not able to follow up on the patients or the post-op cases that we were supposed to be seeing, especially as when we have to see our diabetic retinopathy patients on a regular basis, when they would need injections, they're likely to lose vision. All this kind of, got every one of us scared, and also fear of COVID changed the way we were seeing those patients. Then suddenly everyone was trying to find solutions. Everyone was busy preparing protocols and trying innovative ways to reach the patients. Technology was at the forefront for all to use, and many of us started trying to use our simple telephone to call the patient to check if they were doing well. People are also trying a lot of quick fix teleconsult solutions. Swati, are you able to see my slides?
Yes.
Okay, sorry, I asked
Skim.
you. Thank you.
We are able to see your slides.
Thank you, sir. Pardon?
We are able to see your slides, Kim.
Thank you, sir. Thank you.
Yeah.
We at Arvind also developed some quick fix solutions to create a platform where patients could access doctors directly over video conferencing. This did not have any security, but this was something all of us were trying to see how we could use. Almost every hospital was trying to do different things to reach out to the patients, where a patient could just click on a link and directly gets access to see the doctors. They could show their, with the camera, phone camera, show their eye. At least some of the external problems could be handled at this time. Even Shankar Netralia, in collaboration with Titan Plus at Bangalore, developed a teleconsultation platform where their patients living in Bangalore could reach out to their doctors at Chennai. These Titan Plus showrooms or outlets in Bangalore were taken up, where an optometrist would do a complete eye exam, upload the images, and then do a teleconsult with doctors at Chennai. I think it was very useful, especially for those chronic patients who really need advice on moving forward or follow up. This was very helpful. It was also an opportunity which many of the tech companies capitalized on to find use cases for their video conferencing solution. Many of the hospitals started trying to use these solutions to reach the patients. This is only one way where we could, each of us could reach the patients at their doorstep. But the best thing that happened because of COVID was the introduction of the telemedicine practice guidelines on 25th March 2020. This was a long awaited, but I think COVID pushed it to bring it or release it early on. And these guidelines are really helpful in moving forward with using telemedicine in healthcare delivery. So in all this, it is important to understand that these situations, whatever we are developing, becomes a sustainable solution that addresses the principles of reaching the unreached, removing any barriers. It's consistent and it should be easily affordable by all. We also realized that technology could be an excellent enabler in reaching people, especially at the primary care level. Way back in 2005, we started using technology to reach people at the primary care delivery. We developed what we call as vision centers. For every 50,000 population, we put up a low-cost eye care facility manned by just a simple ophthalmic trained technician, two people there, and this had connectivity to the base hospital, and this was mainly to deliver continuous eye care, primary eye care to the community. So the technician at the vision center would do a complete eye examination as a doctor would do in the base hospital, upload his or her findings to an electronic medical record, then connects over the web and presents the case to the doctor, where the doctor is able to see the electronic medical record, the image is taken, and based on that, he gives an advice to the patient on the prescriptions as required. This is a quick video that shows how a patient these are permanent eye care facilities. So any patient need not go beyond a certain distance. Within about 10 to 15 kilometers, they would find one of these eye care facilities, at least for primary care. So they get, after the this thing, they get a consultation with the doctor, and the doctor actually talks to the patient, which gives more confidence to the patient. So it's like a hub and spoke model where each of our base hospitals is connected to multiple vision centers, and patients could access care through this. And this became a very popular model. The Tripura government was the first to take this up way back in 2008 and established about 40 vision centers. Subsequently, Chhattisgarh, Jharkhand, and recently even Tamil Nadu has set up, Chandra Kumar has taken a lot of initiative to set up these vision centers. We are setting about 33 vision centers in the first phase. Bangladesh has already set up about 85 vision centers. We have been trying to work with them to help them to establish these vision centers. Another condition which needs continuous screening is a condition called diabetic retinopathy, which occurs as a complication of diabetes. This needs early and timely screening to prevent blindness, and this is an image-based diagnosis, so becomes apt for using it for teleconsultation. So telescreening can be done when the patient is going for his diabetic examination by just taking a fundus photo. The technician could take a picture and send it to a reading center or a retina specialist who would create a report, grade those images, create a report and send it back. So the patient need not go to the eye doctor. Just from the doctor's, the physician's office, they are able to reach out and get their eyes examined. At least diabetic retinopathy status could be identified. So this became a way we have been using this for quite some time now. Another condition is the retinopathy of prematurity. Again, it's a very severe blinding condition in premature babies if not identified earlier. So by just screening these patients by using technicians and using the newly developed fundus cameras, you're able to reach out to or screen these babies just staying from their NICUs. The doctor being in the base hospital is able to look at these images and able to identify the diseased eye. Only the diseased babies need to be brought to the eye hospital for further management as needed. Not only having these technologies, but it's also important to address the human resource challenges, because very often you don't get trained technicians even in the rural areas where they are needed. So by developing new devices like such as this EC, which can do a subjective refraction for the patients as a portable, could be taken to the villages and patients' refractive errors could be identified. Another area is the use of artificial intelligence, how this can, just by dragging an image, the retinal images, the artificial intelligence by itself can identify or grade these images in a very short span of time with greater accuracy than human or the retina specialist, and consistently doing it. Such devices could become much more useful in the times to come. And an AI tool can easily replace the time taken by the retina specialist can be replaced by these AI tools, and the turnaround time can be shortened. Like within few seconds, the patient is able to get his report. This is just a beginning. We will see more and more such devices or algorithms that come in future for various other applications. Devices like such as this home OCT is the first of its kind using artificial intelligence, will be available soon. Of course, it's still not available in India, but soon it will be available for people to use it at home care, and also to improve compliance among these chronic patients such as glaucoma, diabetic retinopathy, AMD patients. So COVID has brought a lot of innovations to the front. Future is sure to see how efficiently we use these newer technologies to reach people who need eye care. So I want to thank you for this opportunity to share this. Thank you.
Thank you, Dr. Kim, for sharing those insights. May I now invite Sri Chanakya Mishra, Business Head, Novartis India Limited, for delivering the trigger talk, Netra Nirbhar during COVID times.
Thank you, Swati. I hope I'm audible.
Yes, you're audible.
Thank you so much. Good afternoon and greetings from Novartis. Srimati Ambili Vijayaraghavan, Chief Operating Officer, Aster City, Kochi, Kerala. Dr. S.V. Chandrakumar, Project Director, State Program Officer, Tamil Nadu State Blindness Control Society. Dr. Neena Rani, Deputy Director, Blindness Control Program, Kerala. Dr. Kim, Director, IT, AECS, Chief Medical Officer, the Arvind Eye Hospital. The moderator for panel discussion, Dr. Ronnie George, Deputy Director in Glaucoma Services, Shankar Nithalaya, Dr. Gopal Pillai, HOD, Department of Ophthalmology, Amrita Institute of Medical Sciences, Kochi, and Dr. Bhabatosh Mishra, Director and Head of Products, Claims and Underwriting, Bupa Health and Insurance Company. Eminent panelists and healthcare professionals, media persons, patient advocates, and most importantly, all our distinguished participants who have joined us in this relevant and extremely critical discussion. At the outset, the noteworthy work which has been done by the government is really very, very commendable. Over several decades, to bring to the fore eye health and preventable blindness has indeed been very inspirational. We heard Dr. S.V. Chandrasekhar and Dr. Neena Rani about the great initiatives of mobile ophtha units during COVID and ramping up of teleconsultation. Now today, as we juxtapose this priority to the current unprecedented time, this subject is extremely relevant. It is in one way or the other impacting each one of us here today. So what does coronavirus mean for the visually impaired? What does coronavirus mean for those at risk of vision deterioration due to delayed diagnosis? I was also very, very inspired when I hear about the initiatives about the last mile eye care told by Dr. Kim about using technology to actually reach healthcare to mass population and especially to those deprived of the services which are there in the city. It is very impressive to see how we can reach patients at this point of time with the hub and spoke model wherever they are, especially the use of artificial intelligence to deliver healthcare fast, even in the rural areas. But at the same breath, I also want to highlight the fear of pandemic, which it has brought out not only in the rural areas, but very much even in our own cities, right under our noses. Let me confess, for me, for my family, and most people I know, the fear of the unknown has been far more daunting than the other known evils. We have fear contacting this virus so much that we ignore blatant symptoms because we don't want to step out of our home. We are scared of visiting a physician, we miss our appointments and treatment regime. And this is even more detrimental when it comes to my paternal aunt is medically diagnosed with age-related macular degeneration, a degenerative retinal disease. She lives in Nagpur with a 79-year-old husband. Their children, my first cousins, are based in the US. Recently, my aunt took a fall leading to minor injuries, but unfurling major revelations. On inquiring how and where she fell, she told us that she fell on the staircase and managed to hold on to the side railing, which essentially saved her falling down. Now, one can say that at the age of 64, it is perhaps old age that had lost her balance. But on probing further, she mentioned she couldn't judge the height of a stair. Mind you, the staircase inside her home that she had been climbing up and down for over 4 decades. She underestimated its height and she was losing the sense of depth in her vision. Further on, we realized that she had stopped watching television as it was not very clear. She was still getting confused with medicine labels, and their home nurse was helping her with that. When we asked her when she got her treatment for the last time, then we understood the problem. She had missed 3 visits to her retina specialist. She chose to be quiet about it, and because she feared that going to the hospital due to coronavirus would get her infected. And she knew her children may pester her into getting the treatment if she told them. It is very scary. And this is not happening in rural areas, it's happening in our cities. Every day, we know how elderly in our families are getting anxious. We all have elderly people, elderly relatives who are living somewhere or the other and a lot of time alone. Most of them are living with an equally elderly spouse, consciously or subconsciously posed with the existential question like, is this the end of life or will I ever meet my children? And so on and so forth. When they hear about the vulnerabilities to the pandemic, imagine what their responses are. While I must mention that my cousins had built an able ecosystem around my aunt, but she still fell down. And whenever they called her, they never asked the question that is your vision fine or are you able to see clearly? So an important question that stares us at our face is whether there's a collateral damage that we are witnessing in this pandemic. It is important to be Atmanirbhar, but it is equally important for us to be Netra Nirbhar, to be Atmanirbhar. India is a home to one of the largest and growing geriatric population, with nearly 35% of them living with some or the other form of visual impairment. We have a third of world's blind population, which is approximately 12 million. Cataract accounts for 81% of blindness and an estimated prevalence of 125 million. We have around 12 million glaucoma patients. And as we all know, glaucoma is the leading cause of irreversible blindness. Owing to low disease awareness and associated asymptomatic nature of the disease, the diagnosis rate for glaucoma is as low as 10%. Essentially, by the time a patient is diagnosed with glaucoma, 40% of the damage is already done. It is important to remember that our are vulnerable both physically and psychologically. Their fear, anxiety, and apprehension needs to be addressed, and perhaps regular checkups in and check-ins by the family members or caregivers needs to include discussion around vision. Unfortunately, the concern does not stop at our elderly. That's only one segment of our population. We have the second largest diabetic population in the world, approximately 77 million to be precise. And we all know that diabetes has become the fifth leading cause of blindness across the globe. A diabetic patient is 25 times more vulnerable towards the possibility of getting blind as a healthy individual. Diabetic retinopathy alone affects nearly 18% of the diabetic population in India. These are startling statistics, but the statistics I'm trying to quote to you is before COVID-19 era. Now imagine what has happened in the COVID era. A recent paper of the Indian Journal of Ophthalmology bases a survey conducted amongst ophthalmologists in India. During the lockdown, highlighted that 72.5% of the respondents of this survey were not seeing any patients due to lockdown. Even as we are gradually opening up the lockdown and healthcare professionals are getting back to the clinics, patients are still delaying their visits. And this is not in rural areas. This is happening is also in our cities. This may be leading to worsening of their eye condition and may eventually lead to irreversible loss of vision. If we don't act now, it is difficult to really fathom what these statistics are going to look like in the years to come. At Novartis, we are committed to reimagine medicine and improve and extend people's lives. We use innovative science and technology to address some of society's most challenging and problematic healthcare issues. We discover and develop breakthrough treatments and find new ways to deliver them to as many people as possible. During these unprecedented times, in collaboration with patient organizations and industry associations, we are bolstering patient education and disease awareness initiatives in those who are visually impaired. The fact that we are all gathered here today lays concrete the common purpose that we all share. We laud the government to be one of the torch bearers in prioritizing prevention of blindness. Given that the goal is to bring down the prevalence of blindness to 0.3% in 2020, it is imperative that all stakeholders embody the force to make the states Netra Nirbhar with early diagnosis and timely treatment. To take this message around eye health to the masses, we look forward for the noble government of various states to take forward and take up this mantle as the most trusted voice in this nation, especially during these COVID times. We at Novartis are committed to this purpose and are happy to support as knowledge partners for this endeavor. Thank you so much.
Thank you, Chanakya, for the address. With this, we move now to the panel discussion, patient-physician collaboration to manage eye disorders in COVID scenario. The panel discussion will be moderated by Dr. Ronnie George, Deputy Director in Glaucoma Service, Sankara Netralaya. Dr. Ronnie George has published over 140 peer-reviewed indexed articles, 1 book and 18 book chapters, and has been faculty at many national and international meetings. He is past Associate Advisory Board member for the World Glaucoma Association and is past Secretary of the Glaucoma Society of India, past President of India ARBO chapter. He currently serves on the Education Committee of the World Glaucoma Association, the editorial board of the Journal of Glaucoma, and is the section editor Glaucoma for the Indian Journal of Ophthalmology. Over to you, Dr. Ronnie George.
Thank you, Swati, for the kind invitation. And I'd like to take this opportunity to convey my greetings to all the dignitaries from both industry and from the government and my fellow ophthalmologists. So this today's panel is a very good initiative from FICCI to discuss patient-physician collaboration to manage eye disorders in the COVID scenario. And maybe just a little background. We have heard from many speakers today, but one thing that maybe did not come out is ophthalmology residents were among the most affected people with COVID in New York during this pandemic. The mortality rates among ophthalmology residents was quite high. And this definitely had an impact on ophthalmology practices across the world. Because even if you look at data from America, Mr. Chanakya mentioned data from India, ophthalmology practices were possibly worst hit practices among most clinical specialties, with practice numbers dropping 70 to 80% globally. And it has been a little difficult to come out of it, partly because of all the patient perception issues, which have again been brought up excellently by previous speakers. What we will try to do today in this half an hour or so that we have is to give you an understanding of how it has impacted practices in India, how it has impacted patient vision in India, what precautions have we taken to take care of our people, both working for us and our patients who are coming to see us, and how other people could possibly learn from this experience, and what we hope to get from both industry and the government to help us to reach out to our patients and make sure that we can take care of their eyes and move eye care forward. Keep in mind that blindness is a very, very important outcome. The prevention of blindness is a very important outcome for most healthcare services globally, and the same is the story in India, which has its own challenges with avoidable blindness. So I'm also glad to introduce to you our panel. We have a really eminent panel here today who are from a broad description and a broad spectrum of areas. We have the government sector, we have NGOs, and the private sector. We have Lieutenant Colonel Mariam Matthew, who is an excellent academician. She's a prolific cataract surgeon, having performed more than 7,000 cataract surgeries, and she has served the Indian Army in various difficult posts, including Bareilly, Dimapur in the Far East, and small hospitals all across the place. She is an ophthalmology specialist at the Military Hospital, Chennai since 2018, and we would look forward to her experience in the government sector. It's always a pleasure to introduce Dr. Mohan Rajan. He requires a little introduction in most ophthalmology settings, but I will take the opportunity to just tell you that he's a prolific cataract surgeon. He has done, I think, 120 live surgeries across the world. He has several surgical techniques that he has described. He has multiple awards and has delivered more than 28 named orations. He has trained more than 600 ophthalmologists from around the world and is the winner of a world record of 55 Ophthalmic Premier League presentations. So it's a pleasure to have you on board, sir. It's also a pleasure to introduce Dr. Pramod Bende. Dr. Pramod Bende is the Director of the Retinal Services at Shankar Nethralaya. He is a very senior retina specialist and has vast experience in dealing with very complex retinal problems. He has extensively published on retinal diseases and has trained an entire generation of retinal specialists in this country. He's also won multiple awards, and in the interest of time, I will now move on to introducing Dr. Haripriya. Dr. Haripriya is, again, a very prolific cataract surgeon. She has excellent hands from anybody who's watched her operate. She's basically in charge of the cataract clinic at the Urban Eye Hospital, Chennai, and she also oversees paramedical training at the hospital and is involved with camp activities. Her area of interest includes quality assurance among patients undergoing cataract surgery, and she has developed multiple tools to monitor the outcomes. She also has interest in managing complex cataract situations and has described multiple techniques to deal with this. She has won many awards like the C.S. Resmi Gold Award for the Best Video in AIS and multiple other awards. She has spoken as a guest speaker in multiple national and international forums. It's a pleasure to have her on board. So I'll just move across to the panel discussion now to get a perspective of the actual issues that we face in the clinic. I will start by asking, are we getting more advanced diseases during these COVID times? Dr. Mohan Rajan, would you like to take that question? In your opinion, do you think we are getting more severe diseases at this time? Could you unmute yourself, please, sir?
Thank you. Thank you very much, Ronnie, for the nice introduction. I would like to thank FICCI as Novartis for this very innovative webinar, I would say. It's a compliment of Chandrakumar for the excellent work to the government of Tamil Nadu. And of course, the government of Kerala also, they're doing a wonderful job. And also Dr. Kim for this excellent lecture. And also Dr. Chanakya from Novartis for a nice concepts and how Novartis is committed to the providing the best of the eye care. Answering your question, Roni, I think it's very important for all of us to remember as ophthalmologists, as well as the patients, as well as the public, the government also to know that the patients are delaying the what you call the treatment of their eye care problems, because the eye care is not an emergency and vision is not the life more important than vision. That's what they realize now because of the COVID situation, the pandemic is so severe. And we see, as a result, more advanced problems in the eye. For example, if you take the cataracts, you see a lot of hypermature, mature cataracts, secondary glaucomas, phacomorphic glaucomas, phacolytic glaucomas. Then we see advanced stage of diabetic retinopathy, progression of diabetic retinopathy, because of many factors which I am sure we'll discuss in this course of this webinar. And glaucoma, using the drops regularly, not coming for the regular treatments, AMD, because they've not been taking regular, they've been discontinuity in the anti-VEGF treatment. So because all these problems is a multifactorial, and coupled with the problem of this pandemic, which has crippled everybody, I would say, I think the eye care, the problems we face every day today in the clinical setting is that patients coming with a very, very advanced problems and very, very serious problems, vision-threatening problems in their eye. Okay.
Tony, you are on mute.
I'd like to ask Colonel Mariam Matthew, in the government sector, and you have a more general ophthalmology practice, what has your experience been regarding severe cases and complex cases coming to you? Has the number changed during the pandemic?
Okay, first of all, I would like to thank FICCI, the Novartis, and for inviting me to this talk. Regarding I'll just talk about our hospital. MH Chennai is a 299 bedded COVID hospital. And once the pandemic started, our hospital was converted into a big COVID hospital. We were treating both COVID as well as non-COVID patients. So once this lockdown started, during the intense phase of lockdown, our OPD numbers were almost negligible in the eye department. And it started building up in the month of June. And once patients started coming, I have seen so many patients with age-related macular degenerations and diabetic retinopathies presented in very advanced stages of their disease because they were just waiting for the pandemic to come under control. And I saw some patients with advanced cataracts and all kinds of advanced retinal diseases once the OPD started. So yes, definitely the eye diseases have taken a turn for the worse because of this pandemic.
Thank you, Dr. Mariam. I'd like to move to Dr. Pramod Bende now. Sir, did you notice a lot of avoidable surgical complications related to missed care for children with ROP or with patients with diabetic retinopathy during this time?
Well, outset, I would like to thank FICCI and just to having me here, and good evening to everybody, the eminent panel here. Yes, Ronnie, in fact, as a funny thing, I would say, we have an Indian ROP society. And during this pandemic, in fact, we had an informal discussion that ROP cases are coming down, screening rate has coming down. We thought prematurity has reduced. We all thought probably we could just pull our data and check, because people have more time with the family, healthy lifestyle. Probably they are sitting at home because of stress, though emotional, psychological stress is there. But or either running around for job, everybody is working adult, probably that's a good thing happening to all families. And I think it just, we slowly open up, and I can just tell you last 2 months, yes, that the number of
your voice
advanced
is
ROP
breaking.
cases, yeah, number of ROP cases I am getting last 2 months, and yes, we do get a screening, but number of advanced ROP for surgeries. Average, I'm operating last couple of months, average 7 babies per week. And that's, I never did in throughout my life, rather, I would say. Same thing, diabetics. We have a lot of age-related macular degeneration, again, advanced case. And what previous speakers have rightly mentioned, just people are just scared to come out. Even though their eye problems are there, they just do not want to come out and not realizing that what it can really lead to.
Thank you, sir. It's really sad that children are being affected because they're going to have a lifetime of blindness or visual impairment if we don't take care of them in time. Dr. Haripriya, I'd like you to comment on two things. One, how has your patient footfalls been? Have they been reduced, like as everybody else has mentioned? And second, have you noticed more issues with, Tamil Nadu is supposed to be nearly total cataract blindness free. Do you think that still holds true? I'd like your comments on this.
So yeah, I think over the last few weeks, most of the practices are now seeing more footfalls. So more patients are now coming back to the hospital. But I think for almost 5 to 6 months, there was a lull. And I think the hospitals were closed, patients didn't have access, and also rightly so, because most of the patients with eye diseases are the elderly, and they have a high risk of having a COVID, and they have comorbidities as well. So they do contact the infection, the chance of is higher in the group. So it did seem fair that they don't step out unless it's required. On the flip side, as we are aware, as mentioned by the other panelists, we do see a lot of patients with more advanced disease. From the cataract point of view, yes, we do see patients more mature cataracts, more spherical glaucoma, etc. And we have more of our senior surgeons operating today, again to conserve time, to make sure the complications are reduced as well. So that is what. Yeah. You had another question.
No, the second question, as a follow-up, I'd just like to ask you, what additional, you did mention the two precautions that you take to make sure that surgical throughput is faster and complications are reduced. What other precautions has the hospital taken to reduce the risk of transmission and patient confidence?
So I think one, the patient needs to feel secure. So a lot of the safety measures which all the hospitals are taking is important that we adhere to all of them. It's still not a safe time yet. So the patients need to know that we're taking all the measures, and we need to have the questionnaire administered either to tele-surveys if the patient is going to see an appointment to reduce the amount of contact time before when they check in into the hospital, or through online surveys, or it is in person. So you try to reduce number of people who probably have a COVID exposure entering the hospital. The second thing, which I think all hospitals are adhering to very strongly, is the appropriate PPE. So just like a simple thing with having the patient wear the mask in the hospital at all times is extremely effective, as we would all agree. Like in the ORs, we just have the patients, of course, wear the hospital gown and the mask, and we also tape the mask because, as a matter of practice, if you find the patients either tend to lower the mask or tend to come too high towards the surgical field. So just doing these small things like taping the mask, having the patient informed, I think has also helped during this period.
Thank you, Dr. Haripriya. Dr. Pramod, are we doing anything differently at Shankar Nethralaya, or do you want to add anything more to what Dr. Haripriya said, which I think most of us
yes, in initial phase, I agree, because all of us overreacted, and also because patient load was reduced significantly. So in fact, we sort of, everybody now are talking about bubble. So we actually initially during that April-May phase, we divided our entire actually sort of 3 groups, and every team was working for 2 days and remaining 5 days they off work, and they ensure that one group member does not mix with other group. Other 5 days, patient person does not enter the hospital campuses. So try to just maintain. I think something looking at the symptom period or incubation period. Probably we thought if somebody get exposed, that is a window. Probably we will be able to catch up those people, staff members, so that we can isolate them. Luckily, none of us, nobody got infection within the hospital. Of course, routine other protocols, we are just taking care of thermal screening. Patients are mandatory to use masks. Both entire staff in the campus will be having mask and surgical scrub. Surgical practices, we are not changed very significantly, but yes, ensuring that good ventilation, everybody use N95. We have devised some new, particularly concern about anesthesia, general anesthesia. We have devised some hood-like thing to minimize anesthetist exposure to aerosols. So they cover acrylic hood, transparent acrylic hood during intubation and extubation. So, and COVID RT-PCR, we are not doing as a routine for all the patients, only for a GA patient, because we realize, yes, technically we can do, but even if they are negative, we are not sure. It doesn't give any information. And that doesn't serve as far as your practices. The best way is to follow all standard practices which are advised for all the patients.
Thank you, Dr. P.
Yeah. Very good.
Dr. Paul, sir, do you do anything differently? And one question specially to you, what do you do to improve your patients' confidence about care that you take against COVID when they come to your clinic?
Yeah, I think it's a very important point, Roni, because patients fixing the appointment. When we talk to the patient, we trained all the receptionists, people who give the appointments as well, to talk to the patients and find out what exactly is happening to the patient and take a history and all the patient is saying what are safety protocols we are following at Rajan Care, which is safe for not only for them, for also for us as well. So that gives confidence. The right to the patient, okay, it's safe to come to a hospital wherein the COVID transmission is very, very less or almost negligible. So at that point itself, we try. And as soon as the patient comes in, we have, of course, the 5-step check at the entry level. And we ask for history, and that is the history of travel, fever, and cough and cold. And we do what is called fever check, that is the thermometer and also the pulse oximeter. And then we have make sure that only one attendant for the patient. And we, as Pramod rightly said, and Haripriya also said, we give a 3-ply surgical mask to the patient, because most of the patients come with the cloth mask. We give a 3-ply surgical mask to the patient and plaster it to the nose as well. And of course, wash the hands and use the sanitizer before they come in. So all this is a 5-step check. The 5-step check, we do it in the beginning. And once the patient fails to do the 5-step check, what we do is we have a small slit lamp and examination room right in the entrance of the hospital, wherein we examine the patients, and if there's an emergency, we treat the patient as well, and minimize the what I call waiting time for the patient, stagger the appointment, and dilatation if necessary. Diffraction we try to avoid as much as possible unless the patient wants, and all the protocols, other protocols, routine protocols, which has been mentioned by the AAOS as well as from Shankar Netralaya, we have taken, and we are following that as well. So the confidence, there is a patient, many patients come and tell me, I think you are probably following the best protocols. I've been to many other hospitals, and I think you are the best and all. So that gives the confidence to the patient. So once the patient gets the confidence about it, it should start in the beginning itself. At the time when we fix the appointments, at that time itself we should start. And as the patient comes in, the patient experience speaks for themselves.
Yeah, thank you, Dr. Mohanrajan. And I'd like to move to Colonel Matthew now. Madam, you are in a unique situation of being in a hospital which takes care of COVID patients too. The rest of us see only non-COVID patients and chase out any COVID patients that do come to us with a quick evaluation. So how do you manage to segregate your patients from the COVID patients?
Yeah, actually, being a mixed COVID hospital, we have established a fever clinic in our hospital that is away from the main building. So any patient, any new patient who comes to our hospital is first after there's a hand washing station, and it's manned by somebody who ensures that everybody who comes in is first washes their hands, and then a thermal screening is done. And any patients who reports with fever or any upper respiratory symptoms, or if his temperature is found to be high, is directed to the fever clinic, and there they are screened for the COVID. And the rest of the patients come to the hospital, and they are directed towards the respective OPDs. And all sanitization protocols are being followed in all the OPDs, like social distancing and sanitization of all the equipments and the slit lamp after each visit. And regarding inpatients, we have opened up the I ward of our hospital has been converted totally to a COVID ward, and we opened up 2 new isolation wards, male and female isolation wards. So any new patient who is admitted, whose COVID status is not known, is first admitted to the isolation ward, and the next day morning they undergo COVID testing. If they are found to be negative from the isolation wards, they are shifted to their respective ortho ward or surgical ward or whichever department they're under. If they are found to be positive, then they are shifted to the COVID wards. So these are the protocols that follow. And being a government setup, we have been issued directions to suspend our elective surgeries since the month of March. So we, as of now, even now, I haven't started any elective surgeries. I've been doing only emergency procedures like trauma cases and intravitreal injections.
So let me come back to you, itself now. How do you think this is going to impact your practice in the next 6 to 12 months?
Actually, there has been a marked reduction in our OPD load. Like my OPD started picking up in the month of June, and even now I see only maybe 60% of my pre-COVID workload. It has been, there has been a marked reduction in the OPD load and the surgical load, and as well as, it is going to be not easy to, pick up starting to operate, and even our technicians have been out of touch with, assisting in us in our surgeries for the past 7 to 8 months, and this is going to definitely take time to pick up. It is definitely going to affect our services, but we will try our best and try our best to provide, pick up our services.
Thank you. So I think in terms of the patient care that we take for COVID, everybody has very good protocols in place. Most of us have a place where if you get a COVID positive patient, you can wear full PPE and examine them without any risk to staff, and make sure that you can get them out of the hospital as soon as possible. It's important to have good throughput, get them out of the system as soon as possible. And it's fairly safe, even in a place which is a mixed COVID hospital. All precautions are taken to make sure that your normal patient doesn't mix with somebody with disease. And I think our patients can be quite confident about coming to ophthalmology hospitals. And this message has to go out to the patients. So, Dr. Haripriya, do you have any ideas as to how we can actually get this message out? How can the government help us to get this message out?
So, I think one way the government can help probably is we're having an issue with many patients who would earlier come in through our camp. So, in terms of access, it's difficult in terms of knowing where to go. But they would have access to a primary health center, a PHC. So they do have the community health. So if the government had a way of screening these patients who need eye care and directing them to the eye hospital, that may actually help. That I think probably would be the most, because the patients, the walk-in patients, the patients I think are now a little more informed. They are the ones who are now seeking care, but I think we still have a long way to go to reach our charity patients.
I think that's a very valid point, and I'd maybe just take this opportunity to again ask you, because you have, the Urban Network has one of the largest sort of outreach programs in the country. How has this vision centers and smaller centers, have you seen a similar pattern there too?
Yeah, so actually we found that the patients in the vision centers started functioning back to their optimum capacity very early, much before the secondary and the tertiary centers, because in terms of access, they were closer, so the patients could go there whenever they needed care. So I think that those really started working very quickly. Second thing we did is we tried to talk to the different camp sponsors, the local sponsors who would organize the camps for us. And through them, we told them to patients approach them regarding any eye problem, to direct them towards the eye hospital. So having this network in place was very, so we had kind of many Zoom calls and sessions where we shared that we'll be able to take care of the eye care if they provided the transportation to the secondary or the tertiary hospitals. So this kind of a building a network, and through the sponsors, we try to reach to some of these camp patients.
Okay.
But I think also having the patients informed, like example, if they come to the tertiary hospital as well, we ask them to go back to the primary eye care center or secondary center for the follow-up. Again, to kind of debottleneck the patients at the tertiary center. Plus, in terms of patients' convenience, it's easier to go to a center which is close to them. So I think keeping the patient informed was useful as well.
Dr. Pramod Kande, a lot of patients in many of our centers come from outside the state or outside the city. Have there been challenges in getting these people coming to the hospital and having care?
Particularly, yes, there is a difference. What we are talking about, Dr. Haripriya, I agree with her, and I think similar experience LV Prasad also had with peripheral centers are doing well. But where you have a more referral practice and particularly travel from one state to another state, and in fact, we have a window where even from one district to another district and very strict, rigid guidelines, definitely a lot of patients had difficulty. In fact, a lot of communication we had through patients, like if I come there, whether I have to go in a quarantine for a week or 2 weeks, and then only doctor will see. But I think government is helping out quite well now. They are disseminating information, and specifically somebody coming, of course, these are ever-changing guidelines, as I can tell you probably today again something will be different. So, but now they are significantly reduced, and people, those are coming for healthcare services, those are having obviously return ticket. They need not be in a quarantine. I think that's and they complete their checkup and immediately go back. I think that move, I think definitely help to improve our services. Yes, but then a lot of places transport is still limited, and that's a major hurdle even today. Yeah, and quite a few patients, even we have a few coming from somebody Lucknow, somebody from Gorakhpur, traveling by road all the way coming here because they were in desperate situations. But I think those difficult situations are still there. Things are slowly easing out. Last week again, they have opened up, some 50 more flights can land in Chennai. So I think things are easing out slowly. Probably with time, the major factor I think everywhere for patient point of view, fear was the issue, as we all know. And other speakers have already highlighted that. And with time, as our knowledge is improving, we know things can be handled. We know if a proper protocols can be adhered to. Probably the risk of contamination is not as predicted or as propagated or as hyped, rather I would say, with the multiple media, so social media previously. So, and most of the hospital, including we have our video now coming out, like protocols, the way we follow to boost the patient's confidence. Things are easing out, I feel, and definitely footfalls are significantly increasing. We, I think, reach around 60 to 70% from what we started, like 8% in April, and then we are definitely much better off. And certain specialty, particularly like retina and compared to cataract, where risk of loss of vision and permanent loss of vision is significantly high. Even surgical load, we almost reach I would say, around 90%.
Thank you, Dr. Preeti. Dr. Mohan Rajan.
Yes.
How do you think the government could help us to make sure that the regulations regarding travel and other things are disseminated more easily to people who need to come to the state or to the city?
Absolutely. The government is doing an excellent job, especially the government of Tamil Nadu. As you all know, they have done a fantastic job. But I think the government has got the major role to play in disseminating the information that the safety is much better now today as of what we compared about a few months back. So, because in a pandemic like this, the government has got a bigger role and more powers than anybody else. and everybody, even the common layman, looks upon the government for the last word. Okay, the government, it has to come from the top. So if the government says, okay, you can go and have a safe eye checkup, I think people will start coming out. So the government has to, through press releases, through the TV, mass media, they have to tell that you should go for not only an eye checkup, but also it's very important because they are neglecting their cardiovascular and their diabetes, the kidney functions, the kidney problems, as well as liver problems, and even other problems are being neglected. So we have found that many hospitals, because they're treating only COVID, and people think that only they take care only of the COVID patients, they ignore the other ones. So that is the reason why I think not only the eye problems, but even the other problems are being completely neglected. And this, the government has a major role to play in this. Apart from all the hospitals, private hospitals, we can give our own videos on WhatsApp or the patient information, but it has to come from the top. If they come, because it's the gold standard, the government is the gold standard as far as the patients or the public. I think they think the government is the gold standard, and if the government says yes, everything is safe now, the numbers have come down, and when compared to what about 2-3 months back, see, it is safe for you to travel from one place to another and safe for you to go for an eye checkup. And it is important that you go for an eye checkup. That also the government has to tell. And through various mass media, I think that will create an awareness among the public that they will come to an ophthalmologist or go to a heart specialist or go to a dermatologist much earlier than normal.
Yeah, Doctor.
Yeah,
probably add something.
Yeah, I said a couple of things. I also would like to see incidences reduces now significantly because improved knowledge. We have some unfortunate incidences like chasing the doctors and healthcare workers, and in fact, those in buildings and flats, they were threatening or closing down, locking them inside. So those incidents have significantly come down now. But I think that also what is important. Government can play a role, as Dr. Mohan Rajan said, awareness, public education. If they ensure that, that definitely will help to boost the confidence of healthcare worker as well. Encourage them to come back to work, apart from transport. Also, what is affected here is for all of us is supply chain because of various reasons, transport, manpower, other issues. And government definitely can help us to ensure that supply chain is maintained, not disrupt, because unless you have consumables, even if you want to, you cannot take care of your patients. One thing, again, lot of government schemes we have, and this is again financial crisis, and scheme like CGHS and other schemes, what we other government thing, where payments are generally delayed by minimum 6 months or so. And this is a time we all are cash strapped. Everybody is having a problem. Probably improve the efficiency in government offices. And if government ensure that they can make these payments early, so that also again it will help us to have our resources replenished and probably help us to work better and boost confidence, encourage along with patient as well as your healthcare, our team as well.
Can I add one, Tony?
Yes. Yes, sir.
Yeah. I think government should also influence the insurance companies. The insurance companies should be influenced by the government to pay for daycare services, because the patients are not the economy of the state. This thing is completely at a lowest level possible because of the pandemic, and many people have lost jobs and all that. I think government should also make a effort in influencing insurance companies to pay up as much as possible.
So insurance companies are now open for daycare. Do you think this will have an impact on eye care services?
Absolutely. I think some of the insurance companies are open for daycare. They are reimbursing anti-VEGF injections and whatever, and daycare services, and even for lasers, some of the patients have got it. But it is not opened up fully. So I think if the government says, I think the government comes in and tells all the insurance companies to open up, and that will facilitate a lot of patients to come for, encourage a lot of patients to come to the doctors, to the ophthalmologists.
Even I go one step ahead.
Yeah.
Particularly, they have a fixed surgery cost. Can even they pay in advance to come institutes? Because where the surgery cost is obviously fixed, even if they have fixed certain prices, when the surgery is scheduled, even because routinely they take almost 2 months to pay. On an average, you get a reimbursement. Even if that can be facilitated, initiated, and even sometime even within few days or even sometime in advance, I would say that can be just a dream we can think of.
Absolutely. I think it's a very good suggestion. I really wish we had our health secretary here because he is a very open-minded person, and we could have discussed that also with him.
Yeah. So, Colonel Mariam, I'd just like to ask you, have you faced challenges in supply chain or maintenance of equipment during this time? We haven't really touched upon maintenance because that is the other thing which has impacted a lot of hospitals.
We've had problems in the supply chain because all the funds were being rerouted for buying the COVID supplies. As a result of which the funds that were directed to our department, minor specialties, were actually much less. And also, there was a problem in the maintenance of equipments till the month of June. None of the service engineers were visiting us. But once lockdown opened up, we slowly started having engineers coming to maintain our equipments. Yeah, there has been a problem in the supply chain. Yes.
Thank you. And I think it's important that even though we are called minor departments, we take care of major problems.
Yeah.
So, Dr. Haripriya, a quick comment from you on the challenges in school screening programs now, because that's, I think, something that has been under talked about. These are children who are likely to go amblyoptic if they don't get their glasses or if they're not screened in time. And for almost 1 year now, we have really not done any school screening. I think this is going to have an impact on.
Yeah, I'm sure it will. I think it will, as you said, at different levels. It will. And especially since everyone's at home, they're not using their distance vision. It's all completely screen time. They're spending much more time online. So definitely they're going to have, besides refractive errors, other issues as well. But I don't see how we're going to be able to tackle convince the schools to reopen, because the priority now for the schools would be to have their education online, to have the exams scheduled, to have the practicals online. And this may not be the central focus for the schools. So I guess we don't have much to do. But again, as was shared with other panelists, if we could talk about this more openly in the, to the public, to the government, or to the eye hospitals itself, the children need to have their yearly, if they're wearing glasses, if they're having hazy vision, any symptoms in the eye, to see an eye doctor, because that may definitely help prevent any lasting effect on their eyes. So I think that communication can go through. We don't have to wait for the schools to open, because the parents can still choose to bring in the children who have an eye problem, but those who are symptomatic. The screening part, I think, may take a backseat. And I think the other question you also asked me initially about, do you think that this will have an impact on the CSR, the cataract surgical rate? I'm sure these 8 months of reduced volume will definitely take a couple of years for us to catch up on this backlog. It's going to take a while now. And it's just for one, every subspecialty, I think it's going to take a long time for us to catch up on the patients who actually need care.
Thank you. So I'd like to take the opportunity to thank the entire panel for a very informative and interesting discussion. And maybe just briefly summarize that we have all faced challenges in terms of supply chain, in terms of patient inflows, in terms of patient fears of coming to the hospital. And we feel that it would really, the government could help with awareness among the public about eye care diseases, about encouraging people to come in and for that eye care. It would also help give guidelines regarding travel were more easily available and accessible to patients so that they could come in easily for emergency medical care. And it would help if insurance companies and central insurance companies could reimburse eye care providers earlier than they have been doing, so that there is more money in the system and we can move things forward. So I'd like to thank you all once again and thank FICCI again for the invitation. I hand over to Dr. Swati again.
Well, thank you, Dr. Ronnie George, for such a great discussion and crisp summary of the session. With this, we move to our next panel discussion, private-public partnerships to achieve Vision 2020 goal. The session will be moderated by Dr. Gopal Pillai, who is the head of Department of Ophthalmology, Amrita Institute of Medical Sciences, Kochi. He has 30 international presentations, 300 national presentations, 10 international publications, and 4 book chapters credited to his name. Over to you, Dr. Pillai.
Thank you very much. Am I audible? Am I audible?
Yeah, you're audible.
Yeah. Thank you very much. So first of all, let me congratulate FICCI, the Novartis, the IABP, the Vision 2020, and Apollo for having conducted this wonderful program, Spotlight onto Ophthalmology during the COVID times. Your August 14th program brought together a lot of the bigger people, including MPs, as well as health secretaries, etc. And basically, these programs are very, very important. These dialogues are very important to change what we have right now. So our panel discussion right now centers around a very important part, private-public partnership. Can you please share my slides, please? So the pandemic situation has actually created a lot of problems in the patient's mind. So right from transport, which we were talking about, to the media causing fear factor, fear psychosis in the patient, to actual fear and frightened attitude of both the patients as well as the healthcare providers, and a lot of things which actually prevents a normal ophthalmology patient from moving forward. So we have wonderful panel here, Dr. Girish Rao, who is the president of the Medical Research Foundation, Shankara Nethralaya, Chennai, Dr. Suresh K, Additional Chief Health Director of the Southern Railways, Dr. Ramamurthy, who is the chairman of the Eye Foundation, Coimbatore, and Dr. Anand Rajendran, who is a professor and senior consultant at Aravind Eye Hospital. So can we have the next slide? So vision loss is basically a major problem, and it has a maximum impact on the quality of life. If somebody is faced with a problem of death due to myocardial infarction or heart attack or blindness-filled life for the rest of their lives, most probably people would not want to take up blindness. So blindness can be classified as reversible or irreversible. Some diseases are time sensitive in the sense if you treat now and now only, the disease will be solved. There are some diseases which are time forgiving in the sense that if you treat them 1 year down the line also, you will get back useful vision. So this is a very important concept of time sensitive diseases or time forgiving diseases. COVID is a time when if you do not treat now, he is blind forever. So one-time treatment versus chronic long-time treatment. So there are some conditions where you do one swipe and things are better, like in a cataract surgery, whereas some other diseases which will require multiple chronic, long, drawn-out treatment in which one segment of loss of good treatment would actually have an eventual impact on the long term. Increasing life expectancy population, and also we should discuss, can we catch up with the burden later? Next slide, please. So some of the irreversible time-sensitive chronic treatment-needing diseases are AMD, age-related macular degeneration, advanced diabetic retinopathy, vascular block, some acute glaucomas, and some structural retinal damages like retinal detachment and vitreous hemorrhage. Next slide. So when we looked at Vision 2020 diseases, the main disease that we were covering was the cataract, childhood blindness, refractive error, corneal blindness, glaucoma, diabetic retinopathy, and trachoma. I used this opportunity to look at diabetic retinopathy in particular. Next slide, please. This is two candid. Next slide, please. Yeah, this is the retina, the back part of the eye, which causes a lot of problems, in which irreversibility occurs. Next slide. So we have AMD, in which you can see the stark rise in the age-related macular degeneration after about 60 to 70 years of age, and about 35 to 40% of patients will have decrease of vision. Next slide. And the other candidate disease would be diabetic retinopathy. This is the Ornate India study group, which looked at, you can see the reddish cluttering at the South India, the place where we are actually doing this meeting. So diabetes is very, very common here, and we have 20% of the world's diabetic population. 1/3 of all diabetics have diabetic retinopathy, and roughly 1/3 of them are vision threatening. And according to WHO, after 10 years of diabetes, 2% go blind and 10% will have severe disability. Next slide, please. So, next slide. Yeah. So many government hospitals take a hit because they had to be converted into COVID centers. And suddenly a lot of patients who were getting treatment at that place is now confused. And these are either time sensitive as well as irreversible diseases, which will wreak havoc, and payment and insurance in private hospitals are unaffordable to many. And that is where, in the next slide, the private-public partnership should be a ray of hope. It has patients, eye care delivery systems, government, corporate, pharma industry, and insurance. And together, we have to beat COVID. Next slide, please. So there is a lot of nitty-gritty involved in this particular discussion: the quality of standards for tied-up M-panel systems, corporate social responsibilities, how would the government model function versus the PPP model, usual times, how it function versus the pandemic times, and as discussed previously, what is the payment like in the national schemes or the state schemes, and how do you define based on costing. We can remove the slides. Now over to the panel discussion. So first of all, you can, yeah. So first of all, I would like to ask Dr. Anindra Rajendran, what would be your take on reversible visual acuity loss versus irreversible visual acuity loss? Can you tell me some diseases? Yeah.
Yeah, so I'd also like to thank FICCI, the good government agencies, departments, the ministries, and Novartis for putting up this platform. I think this is a very relevant time and stage for discussing this, surfacing all these issues. And also I'd like to thank Gopal for the very nice PowerPoint and encapsulating all the issues that we need to address and face today. So specific to your question about reversible and irreversible blindness or visual mobility, I think for a long time, and very rightly so, at least from our times of training, a lot of focus has been directed towards irreversible blindness. It was a low fruit. It was something which needs to be addressed. It was a large number, and it's very apt even now. That's important. But coming fast forwarding to where we are today, I think we need to direct more attention, perhaps funds from healthcare managers to this very critical issue of irreversible blindness. So it's important to know that diseases such as glaucoma, retinal diseases, I'd like to raise the flag for retinal diseases there. We know, as Gopal has also shown, that unfortunately India is earning the dubious distinction of becoming the diabetes capital of the world. And with that morbidity, visual morbidity because of diabetes, macular edema, the proliferative complications are exponentially rising. Also, we are now, with the advancement and modern technology, seeing increase in the age proportion of the population. So aging diseases, age-related diseases, age-related macular degeneration is increasing. Lifestyle diseases are increasing. Cardiovascular blocks are happening far more often, and also retinal vascular blocks as a sequelae of that are happening. So we are seeing a lot of damage and pathology happening in the retina, which is constituting a major proportion of visual morbidity. Now, as opposed to cataract, which is which can wait, which can take time, and there won't be that much of morbidity associated with a cataract removal now or later. But with retina, you don't have that much time. So I think that phrase which you coined, Gopal, time forgiving disease, is a very apt one. With retina, you do not have that much time, and it's also something which we've seen even during lockdown and in the post-lockdown period, that the proportion of retinal patients coming in for retinal services and emergency care was continuously there. So that people also do realize that retina, once it's damaged, it's not going to come back. So I think from that perspective, I think focusing to greater extent now on visual morbidity due to retinal pathologies like diabetic macular edema, age-related macular degeneration, retinal vascular blocks, and even, as Dr. Pramod also pointed out, retinopathy of prematurity, which is an absolute tragedy to happen for a child that about to start the journey in life. I think these are the areas where government is beginning to make definitive steps in paying attention. We are seeing more insurance, and we'll talk about that coming up in later segment. So definitely these are.
So I would like to ask Dr. Girish Rao the importance of time-sensitive versus time-forgiving disease, the concept of that for the purpose of the audience. Yeah. You're muted.
I'd like to thank FICCI and Novartis for this kind invite, and also Gopal for putting up this panel discussion. I think, as you have very lucidly elucidated in your presentation, time sensitive and time forgiving, I think these will become new terms in therapy practice going forward. So there are diseases which are very, very time sensitive, and I'd like to highlight that just as in COVID, we are very worried about patients with comorbidities. It is actually these patients with comorbidities who are at higher risk of having eye-related conditions which are very time sensitive. So whether it's a diabetic patient or a patient with a hypertension, a patient who is a child with a retinopathy of prematurity, or a patient with glaucoma, patient with corneal infections, or patient who has had a corneal transplant, patients with uveitis who have inflammation or infections. These are some of the conditions where the success of the treatment not only depends on the appropriate diagnosis, but also the time at which the patient reaches the clinic of the ophthalmologist, and obviously undergoes all the set investigations and treatment protocols which the doctor would advise. So what the COVID has done is, obviously there has been a difficulty in these patients reaching the hospital for the checkup because of the lack of transport, also because of their own apprehension, because there has been so much hype about comorbid patients being at a higher risk from contracting this virus and having a higher mortality. So these patients would have rather face blindness than end up on a ventilator, and that's what initially we thought, that every patient with COVID would end up with a ventilator. So that kind of message went initially. As time passed, we realized that that's not so, and a proper care at the right time can actually obviate most of these morbidities and mortalities due to this COVID virus. And obviously, the initial thrust of the NPCB was for the time forgiving diseases. So if you consider cataract was though one of the easiest to tackle and one of the most simplest of eye conditions which could be tackled on a mass scale. But now we realize that that's probably not the main focus in these areas. There will obviously be a backlog, and we will have patients piled up. There may be a very few percentage who would actually have again fall into the time sensitive zone from this cataract group itself because of the glaucoma or because of the inflammation due to the lens matter itself. But that's a very minor fraction. And India, I think, is very capable of taking care of this backlog in the next few months or a year also. So we can come back to a real normal in a few years. But that's not the case with these time-sensitive conditions. So once they lose the vision, especially in a very sensitive organ like a retina, this vision loss is irreversible. So I think we need to really highlight this importance of time-sensitive versus time-forgiving conditions and encourage patients to come forward for a consultation.
Okay, thank you very much. So next I would move into Dr. Ramamurthy, who is proficient both in the cataract surgeon and as a retinal surgeon. So there are some diseases in which with one swipe of the knife you can correct him forever, whereas there are some other conditions where the patient has to come again and again, year after year, to actually maintain that visual acuity. Can you tell me the difference in challenges faced by these patients, especially in these pandemic times?
At the outset, thanks to FICCI and Novartis for putting this together, and Gopal for a very nice introduction and carrying it further. I think I just have to carry on from where Dr. Anand and Dr. Girish mentioned, because surgeries like cataract and refractive surgery is extremely rewarding. You do it once, the next day patient is happy, the relatives are happy, and that's the end of almost the end of everything that the problem. But conditions like diabetic retinopathy, age-related macular degeneration, glaucoma, etc., are becoming rampant. In 1982, the average age of an Indian was 42, but today it's 68. And as age advances of the population, the prevalence of these diseases also significantly increases. And just like these diseases are time sensitive, again, there is no one-time cure for this. If it's a glaucoma patients, just like diabetes, it's a lifelong treatment that they need. They need to be monitored. The pressures have to be monitored. Medicines have to be adjusted. Surgeries might be needed. And similarly, diabetic retinopathy, age-related macular degeneration, multiple injections, multiple follow-ups, laser foil treatments may be necessary. Sometimes it's very taxing to the patients and the relatives also, for the simple reason, like unlike in cataract surgery, there may not be a dramatic improvement in the vision that they perceive. So, and sometimes the disease seems to have settled down, but rears up its head in 6 months, 1 year later, when the surgeon has to tell the patient that you have to go through the treatment cycle once again. Bilaterally impacted, it could be quite a significant cost drain, number of visits to the patient as well as the attenders to the hospital. So it's extremely important that we educate these patients. It's not a one-shot treatment. These are vision-threatening disorders which not only threaten the vision but can permanently damage the quality of life for that particular individual. So we have to emphasize the importance of repeated treatments, and socially, whether it's the institution or whether it's the government or whether it's other social service organizations, we have to support the treatment of these particular disorders, because this is something the patient has to put up with for a long time. Maybe for the entire duration of their life, they need care for these diseases.
Thank you very much, sir. That brings us to the government activities in terms of Vision 2020. We were the first to start the national program of control of blindness in 1976. And from then on, later on, Vision 2020, and we changed the 0.3%, and now we are trying to chase the 0.25% at 2025. So, Dr. Suresh, so in the government sector, how has the COVID actually affected the normal flow of patients in your setup?
Yeah, at the outset, I would like to thank FICCI and Novartis for having me for this discussion. And thank you, Dr. Gopal. It's a very important question that you have put forward. How has COVID affected the whole situation? See, suddenly our hospital is a multi-specialty hospital where we have right from the basic specialties to all multi-specialties up to cardiothoracic surgeries, one of the foremost center for cardiothoracic and neurosurgeries. So one fine day, COVID transforms this whole setup into a COVID center. Now it has been transformed into a 100-bedded COVID center. Okay, and what has this cost in terms of patient inflow is, now patients are afraid of contracting the disease, because now this is a COVID center. They are afraid whether if I go this place, will I contract the disease? That is one thing. Another thing is, of course, we are all aware of the limited access to public transport, because when it comes to railways, like our government setup, we also operate on a 3-tier system, where we have a basic primary healthcare, a divisional hospital, and a tertiary healthcare. And ours is a tertiary healthcare system. So we get patients from Kerala as well as Tamil Nadu. So imagine someone who has the disease trying to approach us for treatment. It's simply not possible, because from Kerala now, even within it is difficult for people to come to our hospital. So yes, we have seen a significant decrease in the patient load. And another problem which we are facing and continue to face is an acute shortage of manpower, because most of us have been diverted to COVID centers. And almost 90% of my colleagues are now working in the COVID centers. So, of course, there is acute shortage of access to the patients to the facilities, as well as acute manpower shortage, yes. And there is also supply chain, supply demand disturbance that is happening in the government sector. Maybe because of the inability to mobilize the medicines and implants because of limited transport which is being allowed, interstate transport. So all this has kind of complicated the very functioning of the system itself. Hello. Hello.
Hello.
Yeah.
Dr. Gopal.
Yeah. Yeah. Am I audible now?
Yes.
Okay. Okay. Thank you. So we'll come to the private-public partnership. But before coming to private-public partnership, I want to ask Dr. Ramamurthy, who was also working in the All India Ophthalmic Society. So, sir, would you think that this COVID backlog, because of COVID, our graph has gone down as far as our Vision 2020 was concerned? Do you think it can be put back to normal? What do you think about that particular situation? And then we'll go to public-private partnerships.
I think it is absolutely necessary that we put it back to normal. Yes, often we took a back seat, and ICAMs and community health services, eye care services are almost completely not there for the period of about 6 months. I think there is a resurgence as far as eye care is concerned, and most of us are getting our patients back. We are also looking forward to the time when we can go back to our community eye care services, start our eye camps. Of course, caution has to be exercised. We can't have too many people gathering together, transporting fragile older patients to hospital atmosphere. Those things have to be looked into. But fortunately, all of us are seeing the graph is going down as far as COVID is concerned. I think we ophthalmologists have to measure up. The moment we find that the disease is under control, we have to ramp up our services and make sure that 2020 was supposed to be a landmark year. We are all looking forward to this year when we are supposed to achieve a landmark disappearance of preventable blindness. The clock has been set back a little, but then I'm sure we have the wherewithal to go ahead and achieve our goal post, though it might be a little later. And we have to work together for that.
Thank you very much, sir. So now over to the public-private partnerships. The partners would be one with the patients, the eye care delivery systems, the government, the corporate, the pharma companies, and the insurance companies. So, Dr. Suresh, what would the government see in trying to empanel? Like you have been empaneling multiple hospitals, maybe for specialized care. So, what would you look at for the quality of the empaneled hospitals, etc.?
Yeah, first of all, certain basic, even before the COVID situation, as you had rightly mentioned, we do empanel hospitals because it is spread across 2 states. The regular territorial thing, the borders doesn't come when it comes to railways. It doesn't work that way. So we do empanel hospitals for specialized services. And mostly what we look at is for enhancing the services. We do provide basic services. So we are looking at hospitals which can provide or enhance these kind of services which we are not able to provide to the patients. That is one point which we look for. And another is we look at empaneling hospitals at places where we are not able to reach, or hospital people who are places which are quite out of reach from the regular sector. So these are 2 things which we look for in empaneling the hospitals. And of course, the rates, we know we work at CGHS rates, whether they NABH or non-NABH accredited.
Thank you, sir. So now to Dr. Girish Rao. So one of the important part of the PPP would be the corporate. So how would you think we can tie up with corporate in order to provide this care in times of pandemic for those people whom time sensitivity and irreversible vision loss is possible at this point of time?
Yeah. So I think most of the premier or centers of excellence in ophthalmology have had some type of corporate tie-ups with leading corporates for many years now. And but what has dramatically changed post-March is the sudden impact of the COVID. So there were two impacts on it. One is obviously the dire need of the healthcare system to combat the COVID. So most of the funds did get diverted to COVID. But there was also another reason. Another reason was the government tax exemptions, which was almost 100% for a COVID donation to the Prime Minister's fund, COVID fund, versus a 50% for any of the corporates or the hospitals which are doing this. So obviously, though initially we felt that it is very obvious that most of the corporates would go with the government, the Prime Minister's fund. Now, obviously, I think the government should take a step in such a way that either they get the donations coming into these centers of excellence also at 100% exemption, or they bring down the COVID fund donations to 50% at parity. So then it's up to the corporates to decide where they want to put in, because there are corporates which have very strong ophthalmology related CSR activities for years and decades. They would then take a call, because now we all know that COVID is not as malignant, if I may use the word, as what was thought of initially. But at the same time, it's not going to go away anytime soon. It's going to be our companion for at least a few years, or a few months, if not years, until we have a vaccine or some other treatment. So I think now is the time where we again reset and see that the fund does flow in all directions. So we have this corporate responsibilities, and obviously the corporates also should understand now that the emphasis should not be on doing cataracts. So the corporate funding should come for the major surgeries. So whether it's in terms of glaucoma or retinal treatments, as you said, injections, laser treatments, retinopathy treatments. So the corporates should relax the norms and have these funds available for more diversified ophthalmic care. And I'm very happy to say that companies like Novartis and other companies have given a helping hand and given many injections as free for patients who are in the indigent patient category. So there has been...
That's a very important point, Dr.
Yeah,
Girish.
so these companies have joined hands with us, but I think we also know it's only a fragment of what actually the country needs. And we need to do this on a much larger scale. We need to get more corporates in. Initially, I also would like to place on record the gratitude that we had for most of these corporates who supported us with the PPE kits. So whether it's in terms of masks, sanitizers, or IEC materials. So there was a support, but beyond a certain point, we actually need much more, because we are not hospitals which are very cash rich. So once we are not cash rich, we need the working capital to even do our day-to-day activities. And definitely for big setups like Arvind, LB Prasad, Shankar Netralaya, where we do in thousands these camp activities, it's a huge burden. And so definitely corporates should join in. And as Dr. Pramod in this previous session said, whatever pending reimbursements are there from the government for the NPCB, all those need to be cleared now so that these institutions can work up much faster.
Yeah. So I would just like to bring in Dr. Anand here, who is part of the Vitreoretinal Society of India, who played a huge role in bringing in insurance coverage. So what do you think, how is the state of insurance as far as irreversible multiple chronic treatments are concerned, and how has the insurance companies over the years moved on?
Anand, you're muted.
Yeah, I'm audible now?
Yes.
Yeah, so I think that's a very valid and very critical question that you've surfaced here. I think, over the last maybe a decade and a half, penetrance of insurance in medical care has obviously increased, but in eye care has also significantly increased, and more specifically with terms of, for retinal care, we've seen a, significant increase in that. And again, going back to the point of repetitive care. So with retinal diseases, and specifically, it's more about repetitive treatment. And as opposed to, say, cataract, which is a kind of a one-time treatment, with retinal diseases, the visual morbidity is associated with chronic care. So it's diabetes is a chronic disease. So people have understood that, and it's good to note that even government has taken cognizance of this fact. And in no small part is credit due to our pharma partners who have pushed the bug. And I'm very happy to say that VRSI has also helped bring that about. And I think in October there was this statute which came out from the IRDA, which is the insurance regulatory body of the country, which has said that intravitreal injections should be considered for compensation by all the insurance providers. And they've even in another segment even mentioned that age-related macular degeneration should be given precedence, and that should be covered. So different TPAs will have different, it will come out in a different scale. Everybody is obviously struggling with COVID, but this is a great step in a positive direction. And I'm sure the benefit will be passed over to patients through this. So again, this really is another place where public-private partnership is critical.
Okay, thanks, Anand. So over to Dr. Ramamurthy sir now. So you have a lot of patients who come in the private category, and there are a lot of patients who come in the empaneled category, where the costing is a little different between these two patients. So how do you balance these in your hospital?
I think, we have to realize that practicing in India, we have to cater to all sections of the society. And I think all major institutions are doing it. For example, in my center, a cataract surgery can cost 0 to 1.5 lakh rupees. And we have those higher segment of patients who want the best of technology, the best of intraocular lenses, the best of intravitreal medications, etc. We need to take care of them. They expect and they deserve the kind of facilities that are available abroad. But at the same time, it's not something that we can offer across the spectrum to 1.4 billion population. So we have to have cost-effective solutions also. And that's the reason that we have community ophthalmology setups. We have a eye hospital which is catering completely to the indigent population, and eye camps are regularly done. Of course, this is done in a much larger scale by institutions like the Arvind and Shankar Netral, etc. But all of us contribute our might. I think that way, ophthalmology is an extremely balanced specialty, and we are able to service all sections of the society. Maybe it may not be any surprise to the panelists here, but I would like to emphasize the fact that we Indians do 7 million cataract surgeries per year, which is more than the number of cataract surgeries done by China, Western Europe, and United States put together. So obviously, 98% of these patients get intraocular lens implantation. Similarly, whether it's glaucoma, whether it is diabetic retinopathy, all these conditions, we are able to service all the cross-section of the population. Obviously, a lot more work has to be done. And I think in this, the partnership of industry, the pharma industry, etc., is also important. But I'm sure going forward, we'll be able to achieve this.
Thank you very much, sir. So that brings us to the close of the panel discussion. So we learned about a couple of things: reversible vision loss versus irreversible vision loss, time-sensitive treatment needs versus time-forgiving treatment needs, single treatment versus multiple chronic long-term treatment, and the different players. We talked about the the healthcare provider, the eye hospitals, the government plans, the insurance companies, the corporates. So all together, let us put our hands together to combat COVID and bring our graph in Vision 2020 back to course. Over to Swati.
Thank you.
Thank you very much.
Thank you. Thank you.
Swati, you're muted.
Well, thank you, Dr. Pillai, for that summary, and it was a very nice discussion. With this, we move to our next talk on insurance and eye care, which will be delivered by Dr. Bhavtosh Mishra. He is Director and Head for Products, Claims and Underwriting at Max Bupa Healthcare Insurance Company. He's an insurance industry veteran with almost 2 decades of professional experience across life, general, and health insurance industries. Over the years, he has handled a variety of portfolios, including underwriting, products, claims, provider network management, operations, customer service, innovation, and fraud management. In his previous role, he was Chief Operating Officer at Apollo Munich Health Insurance Company Limited. Over to you, Dr. Mishra.
Thank you, Swati, and I hope I am audible. Even if not visible, that would be fine, but hopefully audible. I can't
Yes,
tell
you're
you.
visible and audible.
Thank you very much, Swati. Good evening, everyone. I really can't tell you how scared I am while talking to you, even if virtually. And the seed of this fear was, I think, put in place way back when I was graduating. My then professor, HOD of ophthalmology, Professor Padhi, told me once that, you treat your eye as if it is a brain, because actually anatomically and otherwise it's a brain. And, being a little diminished in the higher function, that scare has been embedded in me for decades thereafter. So the most difficult subject for me in med school was actually ophthalmology. So grace of God and possibly professors that I could pass in a single attempt. But with that background, I would tell you a few things which is very ironical, and I'm sure some of you, but most of you would be aware. If you look at WHO's publication of World Dental Health Report, the first report came out at least 2003 or earlier. But the first World Vision report came out in October of 2019. That's the level of importance WHO assigned to something as important as ophthalmology as a subject, and eye care and eye health as an important subject. While every now and then WHO and everybody will speak of blindness, preventable blindness, etc. But it took time till almost 2020 to come out with the first report on world health, eye health. So something very ironical. The second one, from an insurance company's point of view, I don't know whether you are aware or not. The surgery, the single most important surgery which contributes to outgo in number and quantum for an insurance company is not cardiac surgeries, not GI surgeries, but it is ophthalmology, and mostly it is cataract. So that has been the single most important recurring item on the balance sheet of claims for an insurance company. So for insurance company, it has been very, very important. And somewhere, my personal experience, maybe collectively for all the ophthalmologists and surgeons in India, may not have registered as much because this kind of an interaction never happened. This for the first time I am interacting with noted ophthalmologists. Whereas internally, it has always been a very important subject, cutting across insurance companies. Across companies, this is the fact. Dr. Anand spoke about IRDAI putting few additional provisions under the coverage of insurance for eye care, specifically on intravitreal injections, ARMD, etc. But that is just a beginning. It is perhaps a right step in the right direction, but there is a lot more that can be done in regard of eye care. And when I look at it in 3 areas, if I may say, and purely wearing an insurance plus quasi medical lenses is one is the whole wellness, which is actually emerging as a very important subject, and naturally prevention is a very important aspect of wellness. And there is hardly anything that exists on prevention in eye care as a part of insurance program. Now it exists for well-being, it exists for exercise, yoga. So there are provisions in insurance where insurance companies under our products, we pay for some of the provisions for physical health, not specifically eye care. But there is no such provision that exists in any product for eye care. The second one I would say is curative ones, where cataract continues to be a big one, ARMD, intravitreal, and many more will gradually come, as I understand. And third one is we don't actually look at, and it was spoken about, recurrent care needs and rehabilitation. Again, an area extremely poorly represented in insurance provisions, specifically targeted at eye health or vision. Um, I will give you some examples of some initiative that insurers did on themselves. In my previous experience, we tied up with very large manufacturers of lenses to provide a vision care product, a very small product. Wanted to make a beginning that if you purchase spectacles and if your power of the eye changes by a certain plus minus X diopters, let's say within a provision of, let's say, X months, then the insurance company will pay for the additional cost that you will incur because of your change of lenses or glasses, right? So something as simple as that was brought in. Additionally, we try to bring in that if you encounter certain complications on an existing condition, that complications will be covered. And we defined what those few complications could be. The list could be very small and could be expanded later. But we didn't find much of an uptake. The I think it was not so much about the design and the intent, but more about execution. Maybe this is a subject that could be executed very differently with large partners, and the level of awareness, uh, uh, as we see it, is much low because there is so much of an acceptance of you know refractory errors in our country that people don't treat it as if it is a health condition. A lot of people treat it as if it's a general condition to be expected anyways, whether you grow old or in younger ages, you put on a glass or lenses. There is tremendous level of acceptance, which is something I would request that various societies should bring in to tell people this is not eye care, it's an eye disease. The difference is in messaging. Unless people recognize this is a health condition, possibly the awareness will not grow. And when people recognize it is a disease or a health condition, naturally there will be more demand for provisions of finance. See, health insurance is a subsidiary industry which is conjoined with the healthcare at the hip. Uh, we don't sell health insurance in a place where there is no hospitals because simply nobody will buy it. So it is something that both healthcare and healthcare financing both work together. Now, in a country like India, maybe certain provisions of eye care is affordable right now, but not everything. And when it is not, people demand, and that is where the demand from the market itself came as please pay for intravitreal injections and few other stuff. But in general, for the other faculties, there is poor demand because it is OPD expenses to start with, and for many people, it doesn't pinch. And this leads, at least in a segment, to lead to a much more severe condition later on, where overall cost of management itself goes up. And if it were to be covered in insurance, then something that could have been preventable with little cost earlier unnecessarily ends up at a higher cost. So that is at a awareness level. I think I have just 5 minutes more, so I will quickly try and wrap up. There are few things that insurers also look at. Very, very important subject, which is simply as simple as dialogue. Insurers, we are not designed to look into clinical sciences and advancement in clinical sciences as much as the clinicians and the bodies do. So somewhere we need that education as well, that this is what is happening in the world of ophthalmology. So there has to be outreach from both sides to regularly connect. The other challenge, as I see, is uh, when we are designed to pay for uncertainties. That is whole business of insurances. But at one level, we are custodians of public money. When 100 people pay a premium, we pay for 5 people who need the care. So in a sense, we just simply manage public funds of retail consumers. So we pay for uncertainty of a disease, need of a care, and we thus do not cover something which is quite foreseeable. If a person has a condition, and it's like buying an insurance for the house that has just got fire, is just simply not possible, because it is no more a risk. A risk is something typically which is unforeseen in that sense. Now, having said that, I'll typically highlight one example of FACO, whole cataract. Now, while we see and we cover cataract with a waiting period, what we face as a challenge is extreme variability in cost. That's at one end. And the other end, clinical decision making pathways, somewhere we haven't seen that to be very established and practiced across. Now, India, we must accept 80% is non-organized healthcare. It is smaller nursing homes, smaller bedded hospitals, and so on, and not the larger corporate chains. And adoption of lot of pathways may not be equivalent in all parts of this country. So when a certain variety of lens is used, and when it is indicated, is something neither we understand, neither we see it applicable across. Now, when I refer back to publicly funded schemes like NHS UK, at least if you go to the website of NICE, you will find there are clear guidelines and how to select a patient. And once you have selected, what is the right lens or what right care to be given to that patient. We find multifocal lenses implemented even in a 78-year-old, and then naturally the cost being higher. The arguments that start happening is whether a benchmark exists which an insurance company can refer and say that this is optimal care, right care or not. That decision making, together we need to work on standardizing. The second one, the first one I highlighted is cost. So we do pay for care. So we encounter cataract claims from 16,000 rupees up to 2 lakh rupees a eye. And when I look at some of the bills, and it is not a very wide practice, but this does exist, is many a times it is the only variable is the surgeon charge in some cases. Now, and I personally have looked at enough number of cases. I personally believe surgeons, based on qualification, experience, expertise, skill, must be paid their fees, which is due, which cannot be standardized across. At the same time, I think as much as we can reduce variability and have some guidance in that, and at least the same surgeon, if they continue charging within a narrow range, it helps us process those claims better also. The same surgeon charging 1 lakh rupees in one case and 30,000 in another, without real reason for us to be able to judge, that becomes a little challenging for us. Now that leaves us just 2 minutes. I'm happy to take any questions. So these are some. Over to you, Sati. Thank you. I think I've consumed 9 minutes of the allocated 10 minutes.
Thank you so much, Dr. Mishra, for that interesting talk. And with this, we come to the end of this South India webinar. And that's the third in the series. We will be soon organizing the fourth one, which is the last one in North India. And I would like to thank Novartis India for their support, and Vision 2020 team, AIOS, and the other associations for supporting us. With my sincere thanks to Dr. S.V. Chandrakumar, Project Director, State Program Officer, Tamil Nadu State Blindness Program, Dr. Neena Rani, Deputy Director, National Blindness Control Program and Visual Impairment, Government of Kerala, Ms. Ambali Vijay Raghavan, Chief Operating Officer, Aster MedCity, Kochi, Kerala, for setting the context very aptly. Chanakya Mishra ji, Business Head Novartis India, for the trigger talk. Dr. Kim for the address on the technology for last mile eye care in India, very interesting piece. And to our moderators, Dr. Ronnie George and Dr. Gopal Pillai for excellent moderation and crisp summary towards the end. And of course, not to forget our expert panelists, Dr. Mariam, Dr. Pramod, Dr. Harpriya, Dr. Mohan Rajan, Dr. Girish, Dr. Suresh, Dr. Ramamurthy, and Dr. Anand. And also, special thank you for Dr. Bhavtoj Mishra for this special talk on insurance in eye care. Thank you so much, everyone, for joining us today. Thank you.
Thank you.
Thank you very much. Thank you. Have a safe day.